just to introduce myself and this session. We've just had a session on workforce. This is about patients and the public. I'm Julian McCrae. Some of you will have sat in rooms with me in Whitehall, where over about 30 years I've spent my life in public policy, in that sort of evidence-based policy world, which is really important that you bring evidence into policy making, but sometimes it goes a bit far. We're a set of people who do not know what the public really care about, what matters in their lives, what happens in a frontline organisation, what actually makes a difference in an operating theatre or in a GP surgery. Sit around and come up with whizzy policies that are going to change the country. It is seldom successful as a method. I now part of an organisation called Engage Britain, which is my career mea culpa. It is about how do you make policy if you bring in the public, people using services, people providing those services, and you get them to work together and come up with the solutions, listening to and reacting to the viewpoints of others. And we use all kinds of social science methodologies to do that. And one of the things we did when we sort of set up was we started thinking about, well, what is the agenda that the public want to set for the future, the biggest challenges they see for this country. And it will not surprise anyone in this room that health and care, pre-pandemic, into the pandemic, post-pandemic, has constantly come out as the top issue, the top big challenge that we face as a country in getting it right. And that's increased across that time period. So we've been doing some work around health and care. Two things I want to try and get out of this session on chairing it, so I will probably fail in these. But the first is we've talked about workforce, and we're now talking about patients and public. There's been a really great session earlier about flexible workforce and things like that I was at. There's sometimes a tendency, and humans do this all the time, to think conflict. And to get into these are things that are in tension with each other, and they certainly can be. But actually, I think one of the things we can achieve, collaboration is what makes humans really, really exceptional as species on this planet. And if we're listening to what people are saying and we think about what they value, we'll find there's huge areas for collaboration that actually allow us to improve both the huge issues with workforce, but actually the huge issues which patients are experiencing at the moment. So let's see how that one goes. If this session ends in a blazing row with people arguing with each other, then I'll have completely failed in it. And the second thing is I hope we'll be able to pick up on some of what Nigel was talking about yesterday. That incremental change of things that seem quite small but make quite a big difference to people in their experiences. And hopefully we'll be able to set some practical things that people can do. We'll see how that goes as well. But that's my ambitions for this. Let me introduce the panel who are going to try and make this happen. The first, Miriam Levin, a colleague of mine from Engage Britain, who, since we published the programme, I'm delighted to say is going to be succeeding me as the Chief Executive of Engage Britain. So congratulations to Miriam on that. We have Sarah Sweeney, who's the Interim Chief Executive of National Voices. We have Samira Ben Omar, the Director of Samira Ben Omar Associates and a Trustee of the Nuffield Trust. And Clarke, Group Chief Executive of the Royal Free London NHS Foundation Trust. So they'll be running through the issues at the start. We're going to try and use some technology midway through. I love an overambitious session. So we'll see how that goes. I'll explain it once the speakers of the panel have done their initial comments. So with that, I'm going to hand over to Miriam to take you through some thoughts on the subject. Thank you.
I love the NHS, but I love the NHS, but the hospital lost my notes again, and no one reads them before my appointment anyway. I love the NHS, but I've been stuck on a waiting list for months, and I've not heard anything about when my appointment's actually going to be. I love the NHS, but I've had to fight for the care that I need. I love the NHS, but that was the overwhelming message that we heard when we ran a series of 100 community conversations with people from all different backgrounds, all different places across the UK a couple of years ago. We asked them about What is it about health and care that matters to you? What do you think is working well now? What do you think could be better? We heard so many stories relating to feeling lost within the system, not knowing where to turn. We did some polling. We wanted to find out if those stories were just anecdotes. Were they just anecdotal? Were they one-offs? Or is this something that people recognise across the country? And you'll not be surprised here, yes, those stories are backed up by polling across the country. One of the questions we asked was, people struggle to know where to turn when they needed health treatment. That applied to 31% of people. That is millions of people. There are so many stories from the patient side about what isn't working really well within the NHS, even though there is a deep and abiding love for its founding principles. So at Engage Britain, we wanted to show, though, that it's possible to find solutions to some of those challenges by bringing together the people impacted by them, patients, staff and decision makers. What we started by doing, after we'd heard all these stories, was trying to understand which of all those many, many things that are going wrong in the NHS and social care needed to be tackled first. So we ran a citizens' assembly, it was our people's panel, to find out what people think are the top priorities for change. So the top priority probably won't surprise anybody here. It's exactly what came out of the session that we've just heard about. It's about workforce. So people said, look, we just don't have enough health or social care staff to meet current and future needs. And people can see the effects of workforce burnout that the previous panellists just spoke about. But the second highest priority was a bit more unexpected. And it was about the poor communications between the NHS and people and how this leads to distress, delays in care, and needless harm. So generally, that's not life or death. But it is the everyday harm that most of us have experienced that comes from not knowing who to call to chase up an appointment, not being treated like a whole person, having to repeat your story countless times to different clinicians. People said, look, I know there's waiting lists. I know I'm going to have to wait a really long time to see a specialist, but please, could you just tell me how long is the wait going to be? Just communicate with me so I don't feel like I've been forgotten. And these cumulative negative experiences add up to a loss of trust in the whole system and waste the time and resources of patients and of staff. I just thought what I do now is just give you a few examples of the stories that people shared with us. So these are out of, we put a question out through social media saying, like, tell us your stories, tell us about the impact of poor communication on you. We thought we'd leave it open for like a few weeks, gather a few stories in. We had to close it after 2 weeks after we got hundreds and hundreds and hundreds of stories. We couldn't process them, so we stopped it. But this is just a few of them. My referral to the hospital was lost, and I've completely lost faith and confidence in any healthcare professional, and I'm a nurse. I'm being treated palliatively for cancer. There have been a number of occasions where I've not had bookings for scans that are due or overdue. I don't understand why the different departments don't seem to communicate with each other. I work for an NHS hospital, and everyday lack of communication affects patients and staff. I think it's the biggest problem. Not being told where to go or staff not being told what is happening. We've had a problem with incorrect letters for more than 4 years, and nothing is done. Having to explain my conditions repeatedly to different members of staff I see, especially as I have several rare conditions, is exhausting and makes me feel extremely unsafe. Staff should at least look at my medical file prior to my appointment. What our People's Panel told us was that while it's something most of us have experienced, it's even worse for those people with complex health conditions or those unable to advocate on their own behalf. And this unfairness sits really uncomfortably with people who are raised on this ethos of universal fairness and accessibility of the NHS. But despite poor communications being the second highest priority that comes out of public deliberation, it's nowhere near the political agenda. Politicians and officials tend to focus on institutional reforms. We've heard a lot about that over the last couple of days, not about what really matters to people. Obviously, institutional reform is incredibly complex, but it's much easier to fiddle with the wiring diagrams of the NHS than it is to tackle people's experience of care. People really don't care whether it's an integrated care board, a clinical commissioning group, a primary health trust. They just want to know who to call when they haven't had their appointment letter through. But it's not all doom and gloom. On the positive side, the work we did next was to look at what can actually be done to improve communications, the way the NHS communicates with people. And it shows that there are some practical, relatively simple fixes that put people first, that can be made, and pockets of good practice that can be built on with not too much additional resource. It ties in with what Nigel was saying yesterday morning when he spoke about getting the basics right. So we work with Imperial College Health Partners to find examples across the UK where things are working well, which could be used more widely. And we took those examples back to our People's Panel and to a group of patients with complex health needs in partnership with the Patients Association, and to GP practice managers in partnership with the Practice Managers Association. And they assessed all those examples to see, look, the NHS and kind of people running these examples say they're really good. That, they're holding them up to go, look, these are really good things that are happening. But do they really work? Would they actually tackle some of these challenges that you've identified? And they also thought, what else can be done? How can we build on those examples of good practice to really make changes that's going to make a difference to us? So they worked through that. And the groups agreed on 3 main solutions to tackle 3 big challenges. First challenge was, where do I turn? So to tackle the issue of not knowing who to turn to, where to turn when you need some advice or support, people want a care navigator in every GP practice who'll provide a better triage system, improved information and more support so that people's needs are properly sorted and prioritised. And they want this done by the person who picks up the phone. But they want somebody with the skills to help signpost them, connect them to the right service, a dedicated person who's that communication linchpin, freeing up GPs' time, minimising avoidable appointments and reducing pressure on other frontline staff to provide information or chase up referrals. Existing reception staff are the front line, and they bear the brunt of patient frustrations. And in some GP practices, they do take on that care navigation role, but this doesn't work when they're seen as just the receptionist acting as a blocker to the GP. So what the critical thing is that kind of patients and practice managers talked about was that you need to build up trust in that role, so people feel really comfortable talking about kind of their issues to a non-clinical member of staff. But if that's going to work, kind of having that person enroll in GP practices, they need support and training to do it with a national competency framework monitored by the CQC. And integrated care boards need to have contracts, need to allow practices to close to enable training of frontline staff, which is the case in some places, but it's not universal. So it's not a shiny new idea. Lots of practices do have care navigators in some form or another, and it's a role that people know can be funded through the additional role reimbursement scheme. But it isn't universal, and it isn't consistent, and that's what people want. So the second challenge was that no one has oversight of all my needs. Some patients need more than just better signposting. Those with chronic and complex conditions typically interact with a number of different institutions, specialisms, clinicians, and other staff. And the risk of needless harm and waste through poor communications is far greater for those patients. The case study that really resonated with the groups that we worked with was Connecting Care for Children. So that's a programme that was developed by Imperial College Hospital in London, and it ensures that children with complex health needs receive joined-up multidisciplinary care from a range of specialists coordinated by their GP in a local and familiar setting. There's regular joint meetings, so professionals can discuss complex cases collaboratively. Families get one management plan, which all the providers buy into, so care is consistent. So the patient group that we spoke to with complex health conditions said, yes, please, we'd like that, but for adults, which is both obvious and reasonable. They want a single clinician who can make sure that appointments, treatments, plans, medications are coordinated. This clinician coordinator must have the trust of the patient. It comes back to trust. It's like a recurring thing that we heard over and over again. It's about that trust in the people and the system. And that person needs to have authority and accountability to make sure the system properly serves the patient. Our patients that we spoke to said that everyone with complex health needs should be able to access this service, regardless of where they are in the country, so ending the postcode lottery of services. And lastly, people want all their information in one place, otherwise known as, dear God, not another app. Technology, yeah. Technology offers an obvious route to improving communications, but accessing NHS services digitally is so much harder than shopping or hailing a taxi. There are so many different NHS apps and platforms out there, and they don't speak to each other, they don't share information, even within a single ICB area. There's a really interesting piece of work done by the Organisation for the Review of Care and Health Applications. They created a library of hundreds of thousands of health apps. I did a quick scan and found no less than 34 different appointment booking apps used in different places for different services. That doesn't help anybody. So what do people want? They want a single app to manage end-to-end interactions with the NHS. Ideally, the NHS app, which they're already familiar with. They want something that enables them to manage their referrals, schedule and track appointments, see their whole health record in one place, hold information relating to hospital discharge and track symptoms. They want any tech solutions to be fully accessible and there to be phone-based alternatives so you don't have so much digital exclusion. And in a recurring thing that we heard plenty of times, they want it to be consistent and nationwide, and they want it to be accessible through a login. All of that is pretty hard to imagine until we've got a single care record. But what we're left with, as Julian alluded to earlier, is that we're left with the question of how to incentivise change like this across the NHS, knowing at least that the first two solutions are relatively doable within the existing system because they've already been shown to work. But to conclude, I think we could all think of a time when we couldn't quite believe that the communication for the NHS was quite as rubbish as it was. And we faced the frustrations of its impossibility to navigate as a patient, even if we know the system relatively well from the inside. But there are fixes. For example, around the training of frontline staff in GP practices or clinical coordinators for people with complex conditions that would make a huge difference to people. We just have to find the will and the way to put people's experience of care higher up the reform agenda, letting people themselves tell us what matters to them and work with them to develop the solutions to fix them and get some of these non-sexy, non-shiny ideas embedded across the whole system. Thank you.
Great, thanks, Miriam. Sarah, just coming to you first. I mean, National Voices have done huge amounts in this sort of area. I was just wondering what thoughts you have, what reactions, and also what you're finding from your work. What are the solutions that are coming through in the work you're doing?
Absolutely. I mean, Miriam's taken a lot of those, which is good, a really good sign. So National Voices is a coalition of over 200 health and care charities, and one of the privileges of being in that position is we get to see these patterns between different conditions, between different communities. And really for me, and I think has come strongly across in the work that Engage Britain has done, I think communications is such a big issue across health and care at the moment. I think back, first of all, to my previous role before I joined National Voices. I used to work for the national charity for Gypsy women traveller people, and for a brief stint when I was there, I was a caseworker on the helpline, and for people, there's around 3,000 families living nomadically within England who receive letters, often from the NHS, and part of my role there was to receive those letters, open them up. People would phone almost every day saying, has my hospital appointment arrived? And of course supported people with that. It seemed slightly bizarre and a little bit ridiculous to me, the insistence of NHS organisations sending postal letters to people who don't have an address. And that irony, I guess, has not been lost when I've come into the role at National Voices. I've seen that, for example, repeatedly, people going through cancer treatment, repeatedly getting lots of information about their cancer treatment through letter and it going to an address that they didn't live at and having to try to chase that up all the time. In National Voices, we hear that people's specific communication needs are often not understood or met through health and care services. So 5 years after the launch of the Accessible Information Standard, one of our members, Sign Health, spoke to deaf people, and they found that it was 67% of deaf people reported that they had no accessible method of accessing their GP. It really resonates with research that Healthwatch England did earlier last year, where they put out freedom of information requests to NHS providers, and they found that only a third of NHS providers were fully compliant with the Accessible Information Standard. And it makes me think also then about other people who have specific communication needs that aren't well met through health and care. So if you look at the statistics on the National Literacy Trust website, you'll find that it's around 7 million adults in England, are defined as being functionally illiterate, but I never hear about that group being spoken about when we speak about NHS communications. And it's wider than that too. The 2011 census, it showed that almost 1 million people in England and Wales cannot speak English well. And I personally have accessed health and care in other countries where I haven't been fluent in the language, and it's a really terrifying experience. For any of us, I think, putting our trust into the hands of someone we've just met. I mean, the fact that we let each other conduct surgeries, I mean, I wouldn't do that just to any stranger I meet on the street. It takes an incredible amount of trust, but language and communication and trust are so important and central within that. But there's this kind of thread that comes up, and I think you've really well described that for people with health needs, but particularly for people with specific communication needs. Like, we hear regularly about big issues with clinicians talking over the heads of people with learning disabilities, speaking to their parents and carers, not knowing how to deliver really important health information in the language that matters to that individual, and that feels scary and really disempowering. I've heard countless examples of people with dementia who have memory loss, being told your GP will phone you in this 2-hour period, and people forget that the GP is phoning and go out, to the shop and things and miss the call. And of course, it's been a really big focus during the pandemic on people who are experiencing digital exclusion, as we have that big shift to digital. So for me, we hear all the time about very specific communication needs not being well met across the system, but also it's against this kind of backdrop, I guess, within society, where all the time the communications that we receive are so much more personalised. Uber Eats seem to have a very good way of working out when I have no food in the fridge and when I might be hungry, and I often get a notification then. My hairdresser messages me a day before an appointment and says, you need to confirm before you attend. There's lots of very clever things we can do to understand people's communications preferences and to respond to those. But I think we're really missing a very good opportunity. So I think the last 2 days, we're clearly facing a lot of pressures in the health and care system. I think within this topic, there are very practical things that we can do that would make a very big difference to patient experience, that hopefully would take some of the pressures off the front line as well. And I guess my ask and my call, and I think this is reflected in what Miriam has said as well, is just I think we all want to receive communications about our health in a way that suits us and allows us to make the best decisions. So I think we do need to have a better way of capturing people's specific communication needs, responding to those, and really making sure that is as good as it can be. And I think that would make such a big difference to patient experience.
Excellent. Thanks, Sarah. And I think it's really, all those points are so right. But I think actually when you listen to the public talking about this, we talked yesterday a bit about my view anyway, that there's actually quite a big view of the moral and the ethos of the NHS means that people are prepared to pay more taxes to see it run forward. But one of the conditions that comes out again and again when you listen to people, that moral ethos, it's not just about people who have difficulty communicating, it's everyone else caring about those people having the access. And that's a condition for the NHS, because the moral ethos is about that access for all, those in most need. So I think those points are so powerful. More generally. Samira, great to get your thoughts, and also just on the practice, but also some of the structures, because there's a lot of incentives issues in this, and what might we do to make sure that people experience things that we know work, but how do we get them to work across the system, and not just because in one particular area somebody's actually driven something in a very bespoke way?
So I suppose just to say a little bit about myself. So, I mean, it says Samira Ben Omar Associate, and you can pretty much guess. It's just, they said, what name? And I said, yeah, that works. But very much, I'm a community activist and a community organizer with a background of working in the NHS and in the community. And I suppose for me, there is something about the space in between system and community. And that's actually kind of where we come together and actually kind of make sense of things and how we navigate around things. I just want to start with one story from somebody. I was doing a review on of engagement in a particular mental health trust, and Mary, who was an inpatient at one of the wards, said to me, and she had both some mental health conditions as well as some long-standing physical health problems, and she said to me, you have to be pretty sane to navigate the information, the mental health information, and you have to be pretty well to navigate the physical health elements. And she said, I'm a teacher. So that kind of gives you a sense in terms of when you're in crisis or you're unwell, to what extent are the information that you get and the services that are provided accessible to you in that time of crisis. So there's something around that. I think for me, from my perspective in terms of navigating space, really thinking about to what extent we think about communication, not just in terms of someone else said to me, there's something in the NHS that actually kind of just produces information and leaflet. And she said it's almost death by 1,000 leaflets, and that's what tends to happen, and therefore how do we actually kind of move away from that? What I want to share is just certainly in the early days of COVID, and the impact of COVID, especially on minoritized. I mean, I work predominantly with people from minoritized communities and people living in areas of huge exclusion and deprivation. I think one of the things is that who are the messages that we actually kind of provide? Who is the communication targeted at? And in whose image? So there was a lot of, the information was very clear. You know, you need to wash your hands as often as you can. You need to self-isolate. You need to actually kind of make sure that you are, if you're feeling unwell, self-isolate. For a lot of people, for a lot of communities, they understood the information. It wasn't the lack of understanding of the information. It was the reality in which they live. If you live in overcrowded, multi-generational, multi-occupational households, that information, that communication does not relate to you. And therefore, it's no wonder in the early days we saw a disproportionate amount of people from those communities who actually kind of suffered disproportionately and died disproportionately. So it was interesting earlier talking about the distress and injury to workforce. There's kind of almost I felt very similar to the distress and injury to a lot of the community members and community leaders who were supporting their own community members in actually kind of really thinking and identifying with what happened, and a sense of there was a hyper focus on actually kind of working and connecting with communities, and now it's kind of reverting back to, if you like, to what's kind of normal and traditional in terms of communicating with communities. So for me to effectively communicate and understand communities, you really need to know and understand their networks, their families, their communities, and their experiences, and where they live and how they live, not actually kind of start from the standardizing the communication. There's something about I must admit, I'm not a real fan of translating every leaflet or every information. It's almost kind of a case of hitting the target and missing the point. Because unless you truly know and understand your community, then you understand their communication needs and how they use and navigate and access the services. I think just to kind of go back to the earlier point about navigating that space of in between system and community, because I think it's not just about truly understanding the community, it's also truly understanding and how their needs manifest themselves in our system. And how we actually kind of translate that information into kind of communication, if you like. There's kind of almost 4 rules that I say, and probably those who have heard me say this before are probably sick of me saying them. But there's kind of something about communities do more when they decide for themselves. And there's something about blurring the boundaries between workforce and community. And so how we provide and present the information that we share with our communities need to reflect the needs of those. And it's negotiating with those communities to enable us to do that. I think for me, I see our communities as part of our wider workforce. I mean, we've seen it during COVID. We've seen how they've actually signposted, how they've navigated, how they've helped our system to really kind of deliver on what needs to be delivered, to what extent we begin to do that. The second, it's the role of community and faith spaces to really kind of, they're the lifeblood of local action. So if we want to communicate to our communities, we really need to think about how we use those spaces. We used that during COVID, and we certainly, for those here who were involved in the Grenfell fire, and I was working on engagement, those were the spaces that really helped us and supported us to actually kind of really support communities. The third one is that there is something about in terms of some of the issues around policy and policymakers and how to what extent this is important for policymakers, is that we are, to what extent there is proximity to the reality on the ground with those who are policymakers. So I think there is something about the diversity of policymakers in actually kind of shaping and informing, influencing the way we do things. To me, there is something about race and racism has a negative impact on the health of our population, and the way we communicate has an impact on that. And just kind of following on from the earlier conversation, last point I promised is about outcomes. It's actually kind of measure what people value. There's something about outcomes in a way that we actually kind of make it quite transactional in terms of activities, and really shifting away a little bit from that to something more human, more compassionate, more relational in terms of, I mean, somebody said before, it's not about actually how many activities you've made, but you've done, but also it's about how many friends you've made, how many networks, how many conversations you had. So there's something about what tools that enable us to measure and actually kind of provide those to really kind of then effectively, those are, for me, the things that will help us to effectively communicate with our communities, and especially with those most vulnerable and actually kind of suffer the most inequalities.
Great, thanks, Samira. And I think you raised that just at the end. I mean, it's such an important point, that relational point, and it infuses everything we've been talking about: workforce, community interaction,
absolutely,
interaction with patients. It's so powerful. Caroline, do you want to give your thoughts from running a trust, but also, how you see this in terms of how you're delivering the mission of the trust? How does it work? How does this play into how you're thinking about it?
I've got so much to say, and I was trying to work out kind of where to start. Actually, I'm going to start with the relational point, because some of you will have been in this room 4 years ago where Julia Unwin spoke about the lexicon of public policy and language, and the fact that we've kind of lost the element of kindness and relation and the relational element in public policy, and it cuts through every single part of public life, not just health, and that was happening before the pandemic. And I was really struck, and I'd just become a chief executive in this job, and it totally changed the way I thought about how I was going to lead the organisation. So I think that was a good point. Thank you for gifting it to me. So I run what Jill called a gobble monster organisation. So it's a group of trusts in North London, and of course this conversation preoccupies us in a way that perhaps you wouldn't know from the outside. But I was thinking about how to answer this, and I was thinking actually a lot of what I think was informed by Julia, but mainly it was informed by my experience as a human being and as a patient. And Miriam, when you were talking, I was thinking, well, that everything you said is kind of what I think, and it looks like my inbox at the moment. So, it all comes together. And most people who have jobs like mine will have an element of personal experience. So I have multiple sclerosis. I was diagnosed about 15 years ago with something else, and then eventually got diagnosed with this. And the things that I really, really want are all the things about medicine and biology and probability that medicine is designed to make us anxious as patients, isn't it? So I want to wait less time when I have a test. I want my records in one place. I want continuity of relationship, if not care. And it works really well when I get all those things. So I just thought that piece of work that Engage Britain have done actually is really, really helpful, and I think probably will resonate with lots of people in this room. So I don't think I'm unique, but it does inform the way I think about the organisation. I suppose I was thinking then about some of the things that we've done that have, I think, been helpful in this space, and I don't have lots and lots of answers, but there are some things that I'm really pleased with how we've done it, and I think our staff have liked it. And one of the things at the Free that we've done is borrow very heavily from Intermountain in Utah around the work they did on reducing unwarranted variation to improve clinical outcomes, and actually there's a cost dimension to it as well, but actually it's mainly around consistent patient pathways designed by our clinicians with patients. And the thing that we've done that they didn't do in Intermountain is actually heavily involve patients, and we learned very heavily from the Point of Care Foundation. I think Rebecca mentioned their work earlier. I can see Ron in the audience. We are, very heavily an improving organisation. We're on a journey of probably decades, and we're probably only a quarter of the way into it, but it's something that brings the patient and the staff conversation together. And I was really thinking in that last session, which personally I found quite difficult to listen to, because of course I know all this, but when you hear it played back to you and you are a leader of one of those organisations, it's hard to listen to. But it's the same conversation. It's the same as this one, and we mustn't put a kind of false division in, rather. So the work that we've done with Point of Care Foundation on redesigning clinical pathways with our staff and with patients, I think has been really helpful. It's required time, it's required money, it's required a longer term view than the one the current NHS seems to have, which is all about yesterday and today. And I think one of my jobs, and I'm sure other leaders of NHS organisations and other organisations in this room will know, one of our jobs is to give people an idea about tomorrow's going to come and it's going to be a bit better than today, and we can redesign services. So I think that's an example of where we've really tried to work with patients in the design of our services. I'm really struck by one of the things that's hard for healthcare professionals, of course, is the fear of creating a conversation where you might actually be liable for something in the future. And I think somebody in the last session talked about duty of candour and potential for litigation. I think, Kevin, it might have been you. And actually, that's real. So there is something around trying to create an organisation that allows people to learn, create that culture where actually it's all right to have these conversations and it's a good thing. And so to your point about measuring, that's really, really important, isn't it? And so measuring some of the work. So one of my leaders in the organisation, Ron, who leads a lot of work around improvement, that's a really important thing for boards to really understand how that work's coming together. I want to just give one good example. So in London, some of you may know about this. There was a programme called One London where we asked Londoners how we could use data effectively and properly and what did patients want. Yeah. And again, it's a deliberative event, took place in 2020. I think it's a really good example of asking a question which actually seemingly might be a bit boring, refer back to yesterday's conversations, but actually it was really well received. Again, it took resource, it took time, it took money, and it took a long-term view of what we want to do. And it asked people a very specific question. You have to engage people over specific questions. I think that's my experience. Can't just be a general. So anyway, a couple of examples there.
That's great. Thanks, Caroline. And one thing I would say, you do have to really take time to do this stuff properly, and listen to what people are saying, because they'll tell very immediately if you're not actually listening and responding to it. Look, we're going to throw open to questions in a moment, but I've got to do a quick tech experiment. So we are just got a huge room full of people, all right? There's so much knowledge here, and we do a lot of stuff trying to get knowledge and get information out of people. On your tables, you should see a very big QR code. If you can scan that, you should get into Mentimeter, and there will be a question that we want you to answer on that. The question is, what's the one thing you'd like to see happen to improve the way the NHS communicates with patients? And there are extra marks for people who are giving system incentive answers to that, as opposed to just single scheme bits. But please feel free to put in what you want. And the second thing with this, it's if you want us to contact you afterwards to pick up on your ideas and your thoughts, put your name against that. If you don't want to, don't put your name against it. If you don't want to put your name up so other people can see it, come and grab us afterwards and say that was my comment. But we'd love to follow up on the ideas and thoughts people are having. The final thing is, this is unmoderated. So you can type in, "the chair is useless," and it will appear behind me. So it's up to you how kind and relational you want to be about all this. Great. With that said, and people will be just thinking about thoughts and things will pop up very quickly there. I'm just going to go to a set of questions, and I'll come back to picking up some of these as well in the more traditional style. So I'll just start just at the front there, and then gentleman there, and then working my back through the centre, lady there.
Hi everybody, I'm Rachel. I'm the Chief Executive of the Patient Association. Thank you so much, because everything resonates with what we hear directly from patients, and it was really good to work with Engage Britain on some of that work. I want to draw people back to a piece of work that Healthwatch National Voices and the Patient Association did about 2.5 years ago, which was around communication principles that are on the NHS website. And rather than telling people how to communicate with patients, we pulled together principles so that ICSs and local systems that know their patients well better than national will do could use those. And I'm sure that Sarah and Louise in the room share my frustration at the amount of times I have to tell people from the NHS where they can find a really good piece of work that was done in partnership. For me, everything resonated, and I suppose, Samira, one of my questions would be around the power, and you and I have talked about this before. How do patients have the power? And also, how do healthcare professionals feel the confidence to hand that power over to patients to allow for that true shared decision-making piece of work to happen? Because I think this is all about shared decision-making, isn't it? It's about patients having the right information. And our strategy is around patient partnership and design and delivery of services, and we have a theory of change that looks at healthcare professionals and what needs to be in place there. And I think for me, one of the things that came up as well was the lack of information the patients have. And we're running a webinar with NHS England in a couple of weeks around access to medical records. They're patients' records, and they need their records, because actually that's where it's going to start. And we have 2 patients and a GP and a couple of other people on that webinar, which we can share details of. But I'm mindful of the last session we just had about the burnout within the system and how hard healthcare professionals have worked and continue to work. And we've just run a survey with patients, our winter survey, which we haven't published yet. But one of the things in there that comes out really strongly is when a patient gets to their healthcare professional, they get a good service, and they feel they're working well. So that communication is before that issue. And one of the things that then, okay, so you've got the positive that's come out of the patient survey. The rest of it's not so positive. We still have 67% of patients who say that they doubt that patients will be treated as true partners in their care in the future, that they aren't now and they doubt it will happen in the future. And for me, I think if we could get healthcare professionals and patients working together, you see the motivation in this room. Yeah. And actually, it would be more motivational. So our principles of patient partnership, which we've tested with patients and we've tested with a lot of system leaders and frontline staff, if we can get that right, so patients have the right level of communication, then you will have a more motivated workforce, you'll have better outcomes for staff, and you will have a safer system. The 3 things we've been talking about a lot here for the last 2 days. The last thing that I wanted to pick on in terms of communication and is choice. And the Patient Association is sitting on the task force of the department. And part of that is looking at patient choice. And again, that's come out quite strongly in the survey. Sorry, I'm going to have to read this because they're updating the survey all the time, so it's only new coming out. But, it is showing that there still is a huge amount of work that patients understand their choice. And that from that inequalities lens, Samira, and I'm going to come back to that, if we can't get the right information, our lived experience advisory panel, we had to put together a jargon-busting dictionary. Even I was talking in jargon without realising I was, so I've seen going up there accessible letters. So I think we have to look at the person we're dealing with, get shared decision-making right, and then look at that partnership, and then I think we can address all of those issues. Sorry, I've gone on a bit long.
That's great. Thanks, Rachel. Yes, no, great, and lots of stuff to think over. I'm going to take the 2 questions, just the gentleman here first, and then the lady behind.
Thanks very much. Bob Claber, a paediatrician in London. A quick. Yes, I can stand up. Thank you. A quick comment on trust and relationships. And Miriam, thanks for mentioning Connecting Care for Children. What we learned from that is the fundamental thing. So I guess on solutions, to me, the logic model that sits behind what are the behaviours, what are the activities that you as an individual, as a team, as an organisation, as a system can do to build trust and relationship. Really sharpen the mind on that, and we'll start to get to some of the answers. And my question really builds on Rachel's piece around a single word, and Samira, what's coming here is around power. And I guess I'm fascinated that we've got hundreds of thousands of clinical staff in particular who've been very, very well trained at taxpayers' expense to have deep conversations with patients, with families, and they're extraordinarily good at them. And then when it comes to going and listening to a community group or members of the local population or a patient and asking them, well, what are the things that really matter? What are the things that it takes to thrive around here? We have this fundamental block of being worried about, well, maybe we can't deliver on what you're asking for. So we say, well, we're not going to go and ask you. And I think to help Helen out in the next session, this massively informs how we think about our very centralised NHS. And there's something about shifting power. So I'd love to hear the panel's comments on that.
Excellent, thank you. Thanks for that, lady there.
Genevieve Small, I'm a GP. I just want to I think it's really a powerful session, and it's incredibly useful to have this session immediately after the last one, because I think that we all want to take our communities with us in that journey, but we can't underestimate the resource that takes. And I think Miriam's research really, I mean, that's the stories I hear in my own surgery every day, and that's also I'm part of the problem as well. So it's actually quite difficult to balance all of those things out. I think we need to really start to have a national conversation with our populations around actually what is a realistic expectation, because I think we do have, it's the balance between a universal offer and a targeted offer. Most of the patients who actually hit within particularly secondary care have a particular need set, but most of our population don't have that requirement. They need to have a universal offer that actually needs to be at the level that they need to have it. And we need to start having that conversation with our population so that we start to say, actually, if you're kind of well, digitally active, and actually part of being able to access information and services in a more digitally light way, you crack on and do that so that we've got time to do the ones that actually need the reaching out. And I don't think we're really genuinely having that conversation. And I think it's giving a false expectation of what we as a collective resource can achieve.
Excellent. Thank you. And I think personally, I think that is such a central thing. People are prepared to have those conversations. They understand what the real constraints are. I think sometimes we're just scared to open up those conversations. But let me come back to the panel. There's a few more people who I'll come to in a few minutes in the audience, but just come back to that. Samira, can I start with you? There were quite a few points about power in that, which you might want to...
So I think, I remember the conversation I think we had about power, and it was my question, and I asked you, what is it? Because to me, I mean, I work in a community. So for me, having hard conversations in the community is bread and butter. And it's fine. And you can have hard conversations and you can have mature conversations. I think what tends to happen is when we go and actually kind of have a way of just listening to hear the bits that we want to hear, we take them away and actually kind of not go deeper into the conversation. And I think the conversation we had, I asked you, Bob, I said, what is it about clinicians who can actually tell a mother that their child is dying and they can sit there and actually kind of have that extremely difficult conversation, but when it comes to actually kind of going out and having conversation in the public, there's that block. And I think your response was about power, because as a clinician sitting, you have absolute information in terms of what you're saying, and you have that one person. It's different when you're outside, because there's kind of the perceived unpredictability of having conversations with the community. I think this is where, I think for me, there's something about, this is the space that I talk about a lot between system and community. The idea is not to actually kind of say yes to everything, or to actually, this is about negotiating the space. This is about, there are lots of examples out there around participatory budgeting, about actually kind of looking at prioritization, really kind of making sense of things. But it needs to be an adult-to-adult conversation. It's a mature conversation, and it's not about what do you think of our services. So the starting point we cannot be going out there and asking, how can we improve this service without actually having had the previous conversations about service. There's something about power in terms of communities. There's a lot of conversations about empowering communities. Communities are empowered. They don't need to be empowered. What we need to do within the system is hand over power to communities so that they can really begin to develop, because it's quite patronizing. And this is where the kind of language comes into patient instead of person. We talk about patients and services rather than people and communities. And, the minute somebody steps into our buildings, they become a patient. And I think there's something about actually kind of quite disempowering about that. So we've had the conversation, Rachel, quite a lot of times, but it is about how do we hand over power to communities, because they don't need us to empower them. They are completely empowered.
Great, thank you. Sarah, do you want to pick up from that?
I just agree with all the points that you've made, Samira. I think they're all completely true. There's something about the way that Engage Britain have gone about this and this panel, and there's something about the fact that I think that generally the voice of people isn't strong enough within health and care services, or we would be hearing these things and they'd be acted upon, and it feels like a cyclical conversation sometimes. there's something for me around where until recently lived in Brighton. There's like this green strip of grass that goes from Brighton Pier through to the middle of the city. And for years, there was like set out paths within it, so there was. And for years, everyone kind of like had the place they went to. So people were walking across the grass, and you could see the part where people had like treaded into the grass, and repeatedly people were saying, actually, this is the way that I want to walk across this piece of green space. And the council did it up and put the paths where people actually wanted to walk. And there's something about that within health and care, is that we need to listen very carefully within the system to work out what are the paths people want to tread on. I think when we look at the pressures the workforce is under, I think that a lot of those pressures come from people saying, this is the way that, this is the direction I think things should be working, and it's not working that way. Like, I don't understand the system, I'm trying to get into it, I keep getting caught in the wrong place. So there's something about listening to the voices of people within that. For me, I do think there needs to be investment in technology that better captures patient choice and responds to it. And I do think that there needs to be a greater investment in administrative teams. Like Rachel, so many of the things we hear about is just trying to get through the front door of health and care services, and the great sense of relief when you're in front of a health and care professional. So there's something about really investing in that, in admin teams responsible for communications, and really making sure those teams have all the tools and all the insights at their fingertips to really like line that process up the way that patients actually want to use them.
Yeah, that's great, thank you. And just Caroline, I'd be interested in your thoughts, but in particular, in running an organisation, there's always this trade-off between the investment you have to make and the time you put into it, and the fact that we're running over 100% hot all the time. How do you deal with that as a leader of an organisation? How do you make that space? And do pick up on the other points as well.
I'll come back to that while I digest it. So actually, I want to come back to Rachel's point just about the communication. So my inbox is mainly full of people saying, your admin's not very good, please help me get into your hospital, get out of your hospital, why have I had multiple letters for the same appointment? And sometimes really distressingly, people from their beds saying, help, get me out. And because of course the act of being in hospital is fundamentally just takes power away from you, doesn't it? Actually, you can just get up and walk, it's not a prison. But actually patients, myself included, kind of feel you can't do that. So that's the sort of the level of the challenge. I thought it was just a really, really well made point, thank you. And I suppose there's something for me about, again, the redesign of processes and putting time and effort into thinking about tomorrow, which means you can't do too many things. You know, there, as everybody will tell you, there is very, very little money around, and at the moment, you know, we're just trying to kind of sort of run to stand still. But you have to have really good processes to prioritise, and that's the leadership job, and it's really, really difficult. But allocating scarce resources differently, pushing money out into the community, pushing money into programmes that will deliver much, much better care tomorrow is part of the leadership job, I think. I just wanted to say one more thing. So we did a piece of work recently on, so post-COVID, you know, we learned a lot about how we do and don't communicate. And of course, we communicated oddly during COVID, and we invented some good things and, you know, some bad things. And we worked with an organisation to try and kind of sort of reposition how we work with kind of external partners. And of course, what they told us was, you're a bit didactic, it's unidirectional, you're in broadcast mode all the time. Just listen, you know, and use your staff networks, because your staff expect you to have different conversations externally. Why aren't you talking to faith groups? Why aren't you out in the community? Hospitals are just less good at that, and the big thing I've learned is actually, you know, other people are really good at this. So I'm learning from mental health organisations, local authorities, community organisations like yours, you know. So I suppose the other leadership thing is knowing when to lead and when to follow, and that's quite a big lesson, I think.
Yeah, it is. It's huge. Miriam, I'm going to come to you in the first set of next round, but I just want to take a few more questions in, because we'll run low on time if we don't. So, yes, gentleman just there, and then I want to just pop over there, and then gentleman here. And then there's a few other hands I've clocked, which I will try to get to in a few moments.
Thanks very much. Steve Lane, GP. Just hopefully a quick reflection. So Nigel shared his wiring diagram with us yesterday, which I think we all really liked. Patient voice was mentioned in the bottom right-hand corner. So one suggestion is we need patient voice in all the quadrants of the wiring and hardwired. But I think voice is the wrong word. I think the conversation so far today has mainly been around listening and patient representation and listening to community groups. I wonder whether the panel can give some insight into why we're very comfortable with clinical leadership, lots of clinical leaders in the room. We're clearly comfortable with managerial leadership. Why do we struggle with patient leadership? People who are primarily in decision-making roles at boards, who primarily have a perspective through lived experience of life-changing illness, disability. And I think that is the solution. And if we do that, the culture might change and we might begin to blame the patients and the public a little less than I fear we currently do.
Excellent. Thank you for that thought. Very useful. Just over there, yeah, thank you.
Thank you. Louise Ansari, National Director of Healthwatch England. That was a great question, by the way. Wish I'd prepared that one rather than the one I've got. And really heartwarming to see all the comments there and great presentations. Just one very small story of the hundreds of thousands of stories that we receive. Healthwatch Sunderland supported a woman with learning disabilities to get an easy read version of her mammogram results letter. And it took them 2 years to get an easy read version of mammogram letters become standard. So unfortunately, this is, it is happening all over the country, and systems need to learn to get better in lots of aspects. And my question really is, how can systems embed experience, so people's stories, people's experience, as a metric valued equally alongside all of the statistical and quantitative data that is used on outcomes and performance and quality? Because I don't think anybody's cracked that yet.
Great, thank you. And then gentleman there.
Yeah, hi. Navi Mogul, accidental doctor and not a trustee of the Nuffield Trust. I'm interested in the words that keep coming out of the panel and what your understanding is of the word communities, right? So during the pandemic, I sat at my desk doing what I was doing, looking at the word in front of me pass by with the neighbourhood going backwards and forwards to the forest and back to the houses for walks. And I asked myself the question, what is this thing called a community? And I don't think that we understand or actually have the constructs of community, at least in this nation. I mean, there are greater people than, fantastic people have written about this. Robert Putnam, Emil Drachman, Jane Jacobs, Peter Black. And then, of course, my favourite, which is a South Korean German philosopher. Who knew such a thing existed? But what is the community? What do you think you're engaging with when you use the word community?
Okay.
And what is your sense as an organisation that says, I know what a community is?
Great, thank you. So got really fascinating questions there. Patient leadership, embedding experience, and the what's community. Miriam, I said I'd come to you first to pick up on those, and then I'll work my way through and come back to the floor for I'll definitely get one more round in before we finish.
Thank you. I'd like to pick up on the first two questions raised in this session about kind of how do you bring people's voices, experience, stories into decision making, into thinking about how systems are run and decisions that are made and services that are offered. And to me, the fact that people find this difficult, I find quite difficult to understand. It's just talking to people. Like, I think we make out like it's a really difficult or technical or professional skill you need to have. It's just conversations with people, and people are desperate to tell you what the problems are, and they've got plenty of good ideas about what to do with them. That's what's so exciting about this. It's like, you don't have to have all the answers. We don't have to fix everything. We just have to know how to have the right conversations with people to go, tell us what it is that you really want to see happen. Tell us what it is what really matters to you. Tell us what it is that will be your priority to change, and they'll tell you. And I mean, I'm not in the medical profession. Your world is not my world, so I don't know quite how it is for you. But I wonder if a clinician can have a difficult conversation with a patient or with a family or with a mother, because that's their responsibility and accountability, and they know their stuff so well. But to have the conversation on a community level or a local level or a national level is not their responsibility, or is not their comfort zone, or is not something they're really comfortable about doing. And I think something that maybe we all have to learn to do is just know how to open up those conversations with people, know how to find the spaces, find the platforms, find the ways of just going out and talking to people. And I think sorry, the lady from Healthwatch, you asked about kind of how can systems embed kind of the stories alongside the metrics, alongside the quantitative data. And I think it is as simple as there are certain metrics you can measure about patient experience. I think it is possible to bring quant data into this and really look at it, because if you don't have the data, it's very hard to show kind of a position of change and improvement. And then there's creating the spaces for the stories. That deliberative time, that time to really bring people together to share their stories and share what they think is going wrong and what they think could be done better.
Great, thank you. Caroline, do you want to say something about patient leadership? Pick up on that,
Yeah.
and anything else you want to chuck in as well?
Yeah, no, it's a really good question, and it's quite profound, isn't it? Because of course I'm not a clinician, and I run a group of hospitals. Each one of my hospitals is run by a clinician and a clinical team. That's an important feature of our group. But I'm not a clinician. I've been thinking a lot about clinical leadership and patient leadership, and I've been thinking a lot about what some of the more consumer-led industries have done to get consumers around their board table, and whether there's a kind of read across in health. And I think there is, and particularly as we think about becoming a more digitally oriented industry, we have to have the user voice around the table to design those services. So I think it's a really good point. One person does not make the change, though, so you have to change the culture of the organisation. It can't just be all invested in one person. And you get into all those conversations about, are you representative and all that stuff. But I think that voice has to be much, much louder. So really, really good question. Just on kind of experience, patient experience as metrics, I'm really struck by the fact that we all march to the tune of the regulators, be they the CQC or the professional regulators or NHS England, and those people need to have patient experience up there along with workforce stress, along with access, along with other kind of outcome measures. And until that happens, the overall industry won't be marching in the same pace. So I think that's important. And then that point about what is community, it's different for everybody, isn't it? And it's really complicated, but I think it is going out and it is literally talking to people and not being afraid of the consequences. But you have to know what you're going to do with the consequences, and you have to have a way of prioritising them, because otherwise you come up with all your questions and I don't know how to answer it. So you've got to be prepared for the response.
Yeah, excellent. Thanks, Caroline. And I mean, that sort of digitally enabled, there's a lot of stuff going through, I think people can see on the screen about how do you learn from other industries, how do you do this, but that is just coming, and the way of doing digital is just so different in how people develop things, and every industry has to adapt to that completely. Samira, do you want to just pick up on the community as well?
I also really struggle with the what is community and who represent. I think you can only represent yourself. You cannot represent anyone else. So as a community member or a community representative, I always get anxious when somebody says I represent the whole community. You can only represent yourself and your views. You can bring with you the views that you've heard, but that's all you can do. I think there is something that, even in terms of what is community, there's community within community within community and different communities. It's just how they identify themselves. And it's quite, it's not so structured. I mean, even kind of borough, I mean, Northwest London, where I've worked most of my life, you have boroughs, and people don't actually kind of respect borough boundaries. They kind of, the borough boundaries only exist in our collective psyches, if you like, as systems. They don't exist in the psyches. I'm not going to go to the supermarket somewhere else, or I'll go to this the church across the road. It's neither here nor there. It's just how do we actually kind of understand that, and in designing the information or in designing services, is that we understand that it's not kind of, we're not designing services for our kind of specific geographical boundaries or the way we commission. There's a really brilliant, Justin, I've got a short video and I'm happy to share. He's brilliant. So Justin, and he talks in the video about himself, and he said the challenge about, he's a volunteer and he works in the volunteer drug and alcohol service, and he was he says he was a drug user from the age of 14 until the age of 44, so that's 30 years. And then he kind of said, I wanted to give back, and therefore I was working. He said, the challenge that I've got at the moment is that you've got so many structures. I know the person who comes through the door is not going to want help with quitting. They want to know where they can spend the night. So I know the hostel that will take them on, and I know in which area. But the problem is that we're so confined by actually our own geographies and our services. There's only, I'm told I we're not a housing service, therefore we can't advise on that. And he said, I'm going to do what I'm going to do. I don't care, I'm a volunteer, therefore I'll do what I like to do, which is brilliant. He's very empowered. But there is something about actually kind of defining communities, just understanding the geographies, the areas, how people connect and how people do. So I'm not particularly great at actually kind of thinking a particular community. It's a particular group living in a particular area who have some shared understanding and some shared needs. Now with all the digital age, there's kind of online communities that cross across the world. Certainly during COVID, we had large Somali communities, you know, Suad, who is in Birmingham, and she's a clinical psychologist, and she's phenomenal. And she was delivering sessions in Northwest London. She was delivering sessions in Bradford, in Birmingham, in Canada. So it's about actually kind of how we rethink about our communities and the way we develop our communities. Sorry, that doesn't answer your question, but it's just, I really struggle with that question too.
Okay, great. Thanks, Samira. Sorry, I'll come to you just after. Just wanted to bring in some more sort of questions from the floor. So I think I've got one there, one right at the back, lady there who's just got the microphone, and I thought there was one just there who's been relatively patient. And if we can try and keep these quick for the minutes, go ahead.
Okay. Good morning, everyone, and thank you very much to the panel. My name is Anya Burns. I'm the elected Vice President for Education and Training at the Royal College of Physicians and also one of Caroline's nephrologists at Royal Free. But I would like to say this is my 40th year as a doctor, and I've had a fantastic career. It is a real privilege. I've seen enormous change in the NHS, and this morning, for example, I realised I was down to my third last antihypertensive tablet, so I went on the NHS app, and I have requested my irbesartan, which I will collect from my local pharmacy. Equally, when I started at the Royal Free, I look after complex patients with renal failure. I could be delivered 6 sets of notes, or a patient might have 6 sets of notes, and I'd be delivered the stool chart one, which was of no use to me at all, obviously. Maybe it should have been. Maybe I should have listened more carefully. But anyway, the point is, though, that now I can actually see a patient's records, and that embarrassment of not having a patient's record and that anxiety about having to carry it all in my head and the unsafeness of it has largely, I think, disappeared. So I think my point is about we've managed to convey a lot of negativity to our senior doctors in training, and I think the junior doctor ballot on striking is reflecting some of the negativity. So I think our challenge is to convey more positivity about the successes in healthcare and focus a little bit on good things and lift the general mood of our doctors and try and keep them from leaving.
Excellent, excellent, very good. Points about positivity, always welcome. Do you want to go gentleman there and then Stephen at the back after that one?
Thank you. Adrian Ball, Royal College of Emergency Medicine. There's a fundamental design flaw with the way the NHS serves its patients and that impairs communication. And what we need to be doing is allowing patients to own their records. If you think about how much information is held about us, all of us in this room, by Amazon, by Google, Facebook, and yet the NHS just holds onto this data. And yet we know within bits of healthcare, actually people do very well when they hold their own data. Maternity records, red books for children. Why aren't we letting people own their own records?
Okay, great, thank you. And then Stephen.
Thank you very much. I'd love to follow up Adrian's point, but I will observe your injunction to be brief. I very much welcome the fact that we're talking about what this looks like from the point of view of the individual user of NHS services. But what I want to do is to, rather than the structures and the politics and all that, but I do want to link it back to yesterday's discussion about those structures and in particular about ICSs and ICBs, because we've had a discussion this morning about how the NHS has a dialogue with a community. And we've had the question, what is a community? That's a question that is at the heart of local government. And we can't have a dialogue of the NHS with the community and a parallel dialogue of social care and other public services with the community, and then say we've got an integrated system. We need to integrate the dialogue.
Yeah.
Yeah, it's a very good point. And I might add that it's very easy to actually include more than one person from the government perspective in a dialogue with people. It works very nicely. I said there was one more question there, and then I'll come back to the panel.
Okay. Dilip Paliraja from the Richmond Group of Charities. I think there's a bit of a danger in this discussion of seeing communication and kind of technology as the solution, and actually, you kind of forget that care is relational. It's about knowing your patients, and patients knowing the teams that are caring for them. And I think as we move to more at-scale operations, particularly in primary community care, multidisciplinary teams, neighbourhood teams, we have to design in the relational element, because that's why people have to keep telling their stories over and over again, because they're seeing a whole load of different clinicians. It's not just fixed by shared care records. It's also making sure that the people who are caring for you are talking to each other and know about you. And I think that's the challenge as the NHS moves to much more at-scale industrial operations, to maintain the personal and relational element of care.
Absolutely.
Yeah, no, I think that's exactly right. And the communications is really, it's about people really desiring some relationship. Yeah. That is really what's driving a lot of this in the background. So look, can I come back to now, Sarah, I said start with you. To pick up on, we had loads of stuff there, but positivity is one of the things I hope we can pick up on in this. But own records and the points about how we join up the different parts of the systems. Anything you want to pick up on from this?
I agree with all the things that have been said, and it makes me think, I think we've come a long way, Anya, and I think you're really right to recognise that. I think there's some really practical, very tangible things where things have improved, and that gives me hope that more positive things can come for that. I kind of brings you back to that point in patient leadership, I think, and where we're at with that and what that might do next. And part of me thinks that there's something around any organisation that's a comparable size to the NHS would typically spend a lot more money on user design than the NHS does. So I think there's a really big argument for that. I think there's a cultural element of this. I think the NHS is quite a hierarchical, if I can say the word, organisation, with clearly tons of clinical expertise. We need that. And there's something about how we value different people and different perspectives. I think within that, even the stuff that is where it's trying to engage with communities, I've often found we almost try to give job titles to the people who are going into communities, and it's not really how communities function. You don't, when you hang out with your friends or family, you don't say, this is my job title. That would be a very strange thing to do socially. So there's something about that. There's something about diverse forms of representation in that work, and that coming through strongly. And I just wanted to maybe finish on two notes, which was two positive things of initiatives that I know of where communications has improved with particular groups experiencing inequalities. And one is, I think, an unwitting example of the move to electronic prescribing, electronic prescribing. I'm aware of, for example, people who live on boats across the country who traditionally have found it really hard to engage with primary care because you expect to be fixed in one area, who've been able to access prescriptions so much easier because of that. And the second one is one of our members, Sign Health, have been advocating for years because there's a big issue where, we all have the issue with access to mental health, but for people who are deaf, you have to wait for both a BSL interpreter plus someone who can give you that mental health, and they're delivering a service that combines those and improves it. So there are promising things that do build on kind of relational elements. There is a lot more that can be done. I think there's a lot of hope. I think this is one of the issues these 2 days that we can really change things in.
Yeah, excellent. Thanks, Sarah. Right, I'm going to run through 4 comments, but do keep them brief because I'll get in trouble with Nigel if you don't. Miriam, start with you, Samira, and then Caroline.
Sure. Just coming to the last question that was raised about we've got to focus on the relational, not the tech. I completely agree. And the participants that we spoke to, most of the ideas that really resonated with them were the human-to-human interactions. And like I said, but it wasn't so much about the relationship between themselves and their clinician, their doctor, which they said, that's marvellous. When we actually are on the ward and we're dealing with the nurses, they're amazing. That's not the problem. But it's the bringing the human communication back into the beginning of the system as you're trying to enter the system and trying to get your appointment, trying to get your referral. That's where people wanted that human interaction and that relational aspect. And that's the thing that is not so hard to do, but it's something that we have to put on as a priority.
Great, thank you. Samira.
Yeah, just quickly, I mean, we're talking a lot about trust and relational elements that are really quite important in working with communities. I mean, if you look at and this is where the challenge, if you look at ICSs and their definition, on NHS England website, and it says something about partnerships of organisations that come together to plan and deliver joined up services. There's nothing about people there. There's about people coming together. I mean, we did do some work on redefining that, and people said to me, if that's what you want to do, go away and do it. That's your job. But if you want to talk about a different way of thinking based on people, then that's a different type of conversation. So there's something about also the language that we use in structuring, restructuring, or articulating and communicating what we're trying to do. And we just need to actually kind of negotiate the transactional with the relational if we really want to talk about trust and building trusted relationships.
Yeah, I think integration is one of those great words where we hear when the public say it, integrate systems and organisations. They mean integrate a set of conversations.
Exactly. Around me. Yeah, absolutely. So three things. So yes, of course, we should own our own health records, and that absolutely, Bob, to your point about power, that's how you get power, partly, isn't it? By having actual sight of your records. Secondly, this point about kind of relational healthcare, we can't ignore tech. It's coming, and we have to embrace it. If those of you that like a good read, Atul Gawande wrote a really good article in the New Yorker several years ago about the implementation of electronic patient record systems in his health system, and how it's that it creates a new set of problems, which is I'm talking to the computer, not my patient, and they lose. But so we need to do both. I think that's really important, and you can't pretend it's not happening. Thirdly, the statistic I learned over Christmas, and I don't know if this is true, so someone might want to tell me over coffee, but I heard that 2/3 of kids in schools now will have jobs that don't yet exist. That blew my mind. It was after Christmas lunch, and I'd drunk quite a lot. But I mean, that's amazing, isn't it? So we've got to make sure that isn't just a tech conversation, which is how it came up. And some of those kids have got to be doing the human factor stuff as well.
Excellent. Thank you. Thank you, Caroline. And thank you all for your participation in this, for the questions and for the comments that fed in on the electronic stuff. But can I join me in just thanking our panel for an excellent discussion?